Call this meeting to order at 6:00 p.m. Madam Clerk, can we do roll call, please?
Director Burnwood.
Here.
Director Gupta.
Here.
Director Menard. Director Proctor.
Here.
Director Berger. Here. Director Valdez.
Here.
Director Garcia.
Here.
Thank you. Would everybody please stand for the pledge of allegiance? Ready? Begin.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you. Now we'll move on to consider approval of agenda. In the case of an emergency, items may be added to the agenda by a majority vote of the Board of Directors. An emergency is defined as a work stoppage, a crippling disaster, or other activity that severely impairs public health, safety, or both. Items on the agenda may be taken out of sequential order as their priority is determined by the Board of Directors. The Board may take action on any item appearing on the agenda. Do you have any changes or approval to the agenda?
We're going to be changing the closed session, correct? And
We're
moving
close
it
to the end.
to the end.
So we'll hear closed session, move item 7 to after item 15. Do I have a motion to approve?
I so move to approve with the change of moving closed session to the end.
I second it.
I have a motion by Bitzel and a second by Proctor. All in favor say aye.
Aye.
Any opposed? Any abstention? Motion carries. Now we'll move on to public comments. At this time, the board will hear comments on any agenda item. If any person wishes to be heard, he or she shall stand, address the president, identify self, and state the subject for comment. Time limit for each speaker is 3 minutes individually per item to address the board. Individuals who wish to speak on multiple items will be allowed 4 minutes in total. A total of 15 minutes shall be allocated for each item for all members of the public. The board may find it necessary to limit the total time allowable for all public comments on items not appearing on the agenda at any one meeting to 1 hour. Do we have any public comments?
Good evening. My name is Ron Rubin, spelled R-U-B-I-N. It's been in the minutes incorrectly on the 9th of January, the 23rd, the 30th, and then on January 23, Dr. Fareed's name was misspelled. And so to have those corrected, please. I don't really care about my name so much, but in a Hispanic community, sometimes that happens. But I've never been called Mr. Goodman before. Thank you. Again, I come to you to talk to you and understand something that I learned this afternoon, that El Centro Regional turned you down again. So, no, that's not true.
I would say that anything that you've heard regarding negotiations is speculation at best, considering it's all closed session. We have a non-disclosure agreement.
Let's hope that it's true, and that you guys, wise up, because they have not negotiated with you in good faith ever since the start of this. They only look out for what they think is best for El Centro and not for Imperial County. You're here to look at the best healthcare project for Imperial County, bar none, and that's your main goal. If you take on El Centro in the way everything is set up right now, it will fail because of a lack of funds. You don't have operating funds. Nobody has changed what's happening in El Centro. They lost $8 million in the first 6 months, and they've done nothing but lose money without San Diego, UC San Diego, ever figuring out what's wrong. There's something wrong there. And what's wrong, the biggest thing is what's wrong, is that they're stealing El Centro's customers right out from underneath their nose. And have been since they got there. And I think that I have that on pretty good basis from the standpoint I've talked to people that were in the finances before they started and employees that say they've taken perfectly good patients that could be handled in El Centro and taken them to San Diego because they could pay. The El Centro, has put in their last contract that they have no fiduciary responsibility. Let me remind you, you do have a fiduciary responsibility to this new direct district. But they have recused themselves of everything and anything so that nobody could sue them for the liability of taking El Centro Hospital from a moneymaker to a loser. And that they are heartless. They have no shame in what they've done. And I really urge you, don't buy El Centro right now. Let the chips fall where it may, and then by that time maybe we'll have something that we can really do. But don't play into their game. Their council members got rid of people that read their information and studied, asked questions. The city council today doesn't know how to ask a question. And you might think I'm just full of hot air, but again, they're nice people, but they don't do their homework. You guys know how much homework there is to do. You're just seeing the tip of the iceberg. Believe me, it gets heavier, and especially if you have El Centro. So I know I'm running out of time. But I'm going to keep saying something until somebody says we get the message. Thank you.
Thank you.
Good evening, everybody, and welcome. Good morning. My name is Yolanda Smith. My nickname is Yo-Yo. I work the front. I work in pediatrics where my little bambinos are at. As we move forward, there's a lot of changes. So I'm just asking, hopefully, throughout the movement, that please review the pediatrics. Bambinos are being transferred out when they can be here. We do need specialty physicians. I'm an advocate of children and parents. That's all I have to say. When you're doing your planning, please place a little thought for the pediatric department, and I brought it up. I'm sorry I cannot pronounce his name, but I'll say Mr. B. Okay? Thank you very much for your time.
Thank you.
Thank you. Do we have any other public comments? Now we'll move on to item 8, the consent agenda. Any member of the board, staff, or public may request that items for the consent calendar be moved for discussion. Items so removed shall be acted upon separately immediately following the approval of the items remaining on the consent calendar. Do you have a motion to approve the consent?
I so move.
And we're making the corrections, correct, to Mr. Rubin's name and Mr. Dr. Freed's name as noted?
Yes.
Okay, thank you.
Do you have a second?
I'll second.
I have a motion by Berger and a second by Garcia. All in favor say aye.
Aye.
Any opposed? Any abstention? Motion carries. Now we move on to item 9, board comments, reports on meeting and events attended by directors, and authorization for director attendance at upcoming meetings and events. Do any of the directors want to give a brief report on any events attended? Okay. Then we'll move on to report by education outreach ad hoc.
Thank you. Can you, I don't think the mics were on. Can everybody hear me okay? Yeah. So this is a message from our consultant, our marketing consultant, Frank Salazar. So I'll be speaking in his person, okay? So we are excited to share that we've successfully transitioned to the new Imperial Valley Health.com website. And then, so that's actually a new URL as I understand it, imperialvalleyhealth.com. And it's been a smooth process thanks to the collaboration with our dedicated IT hospital staff. And we'll continue to work closely with them to refine and enhance the site as needed. In addition, we've been working alongside the administrative team and CEO to review our current marketing and media efforts. We've started a thorough assessment of exciting outreach, including digital media, print, and billboards, to identify opportunities for improvement. Once the evaluation is complete, we'll be providing a strategic recommendation to strengthen our visibility and impact. And in addition to that, we've had some press releases as well, and we had a grand opening. There was a grand opening today in Calexico for the new emergency center headed by Dr. Tyson, the All Valley Urgent Care, and then also just a little shout out to Mr. Tomas Verheen. He was in an interview on Univision as well on our behalf. So that concludes my report.
Thank you. A report by AB 918 Negotiation Committee. Mr. Sean.
The negotiation committee has met a number of times since our last meeting, both amongst ourselves and with council and our financial consultants. We sent another round of edits to our counteroffer over to the city and ECRMC, and we received a counteroffer today, which we'll be discussing in closed session.
Thank you. Now we'll move to item 10, update and discussion regarding distressed hospital loan modification application.
Okay, so I put the application information in your packet just so you guys can kind of see what
We're going to do. There's 3 ratios that we need to hit, and we have a very short timeline where one of them we would be eligible for. I don't know because we also have to do a 24-month projection, and that one ratio gets better because we pay off some of our debts. So I'm not really sure if they're going to approve us based off of that projection or not. So that's more of an informational for you guys to know. I'm submitting most of the stuff tomorrow. They're supposed to have it within 90 days of the first payment, which is May 1st, but they didn't release this till February 3rd, so that was already past the 90, but they're allowing me to still submit it since they didn't have the application out yet. So then I also gave to you guys, and I was requested a worksheet of the distress loan, how we were going to spend the money. When we applied for this, they had asked for a listing of the capital expenses or whatever we were going to do with it. So I gave you the listing. Everything other than the last 3 columns is what they got exactly in their loan. You can see that the total we asked for was $29,700,000. We got $28 million. So most of this stuff has either been not paid for yet, but we have started the process for it. So on the right-hand side, you'll see there's a to pay. A lot of our stuff we still have to pay for. So example at the top, your chillers. We've already started that process, so we still have about $1 million to pay, and we paid $145,000. So through all of this, we have already paid $9.1 million out of the stress loan, and then out of everything that we have already paid and will end up paying off of this list is $19.9 million. There are a couple items that we on here that's not highlighted. Example, elevators. We have talked about, we do plan on replacing them. We haven't gotten into a contract or approved that, so I don't have any of those numbers listed to be paid yet because we just haven't started that process. So if you have any questions on the details of this, it ranges from, as you can see, mostly capital expenses, some provider compensation, employee compensation, some other systems, revenue cycle work, nurse system things that we have been, that we were working on.
Carly, I had a question.
Yes.
You have on here the fluoroscopy,
Yep.
and I thought we traded up for the CT.
Yes, the CT added down at the bottom. There's 2 things that were not on this list that we are going to, and the CT was one of them. The radiology team decided that the CT was more important, and so that is why it's just left up here because I didn't want to change the list that I gave to the state because I do have to submit it again with this application, and then just added the CT at the bottom. You can see on this side, it says radiology wanted this, and I see it cut it off, but over fluoroscopy.
Okay, thank you.
Can you email us to the board?
Yep.
Please. So there's about $20 million left in the distressed hospital loan funds that haven't been spent.
No, there's 8 million. We've already basically promised 20 million to be spent. There's 8 million left. So that 19.9 is money that we have either paid or we've already basically promised to pay for different projects.
Because I don't see $8 million on here anywhere.
I don't have that list on here, but we got 28 million. And so,
Can you send us something that shows the actuals of like what's been paid?
yeah, that's on here, but I'll send it to the email and explain this worksheet a little bit better.
Yeah, because I'm not seeing $8 million left over anywhere.
Right, so this here on your column here, it says total spent and promised to be spent is 19.9 million. So basically 20 million. We got $28 million of a loan. So I just don't have on here the balance left.
Okay, that would be helpful. And then I see on the wages,
Yep.
you guys went over by $1 million. And
Correct.
so did you take funds from that loan, like somewhere else? That wasn't that million? Did you pull that out of the general fund, or where did that come from?
It's operations usually, but we can move it from here. There's nothing in the documentation that said that we couldn't use. If you see too, I have a contingency of 15% of 3.9 million. So you can move part of that contingency funds up into any of these other items that would have gone over the original estimate.
Okay. And can you, is there a way you can highlight which ones went over?
Yep.
That'd be great. Do you have any questions from the board?
With regard to the elevators, are things old or are we replacing them? What's going on with that?
Okay, go ahead.
Yeah, they're pretty old. We do have some need to replace them. We actually have one of the circuit boards is out on one of the newer ones, and we're being told that they don't make that anymore, so they're finding other ones to try and fix so that we can fix that other one that's down. We're kind of I will say though, with the elevators, we're in a weird spot. So it's not a terrible amount of money, but it's still a lot of money. And if we do the seismic upgrades that we need to, realistically, that could be included in there at that time. But we would be kind of piecing it all together, with Frankensteining it, if you will, to get to that point if we don't do that. And I think that we're in a spot where, from a customer service standpoint, obviously we need those elevators to be working. And so even though that is the case, we probably need to actually move forward with it and replace it because they're Frankenstein.
And the elevators they're two different ones, sometimes in some facilities.
So
there's commercial and then for people, or is it just combined?
It's combined. There's one of them on this first floor here at the end of this corridor. There's 2 of them together. One of them has doors on both ends, so the folks from the kitchen can just take the stuff over and take it up. But that's the only one that's like that. And then the other side, as we get closer to the OB, there's an elevator in that area as well. So there's 3 total.
And how's the one in the OB department?
That's the one that's always down.
Oh, really? And it's a newer one? Is that a newer one?
Yeah, it's a newer one.
Sorry, I see stuff here also for the pharmacy. Have those not been started?
So the pharmacy is kind of in the same boat, but realistically, that figure, I can also say if the El Centro piece comes together here soon, then there are opportunities with what El Centro already has that's brand new that we can actually use, and we wouldn't have to use some of those monies for this. So we would actually be able to save some money on that. But we do have some areas in there, specifically on the compounding room, that is problematic, just size-wise and everything else. They're in they're in 3 different locations right now, and just because they don't have enough room, and even the largest area that they have, it is very, very tight.
What about, I see in here too, there's 203,000 for foundation. Is that for that project monies that came in, or was that a donation to the foundation?
So the item on here, the portable X-ray, we have purchased it, but the foundation actually purchased it. So we won't actually be paying for it. It was just on here that we were going to, and then they decided to purchase it. So that's why it says that.
Okay.
Chris, would you happen to know how many Da Vinci machines are at El Centro Region?
I believe they have 2, and we have 1.
And we have the newer one, right? Like
The newest one, yeah.
The newest one.
Yeah.
Are they the same kind of, like identical type of equipment, or are they a little bit antiquated, theirs?
They're very similar. Usually what it is there's upgrades to different, like the system components of it and the software piece of it. I couldn't tell you off the top of my head. I don't know what model that they have. You know, it's kind of like you can buy the Toyota Corolla, the LX, the EX, or the ELX kind of thing. So it's very similar in that nature to, and it also will depend on like the what we're going to use it for. Like the more complicated procedures require more than some of the more simpler procedures. I don't know what they have compared to what we have. I have not seen that.
What's the building in El Centro for 3.9 million?
That is the ambulatory surgical center that we just purchased.
First of all, I want to thank you for this. Second off, I'm going to give you my speech that I gave many, many years ago to the CFO of the school district. I do not like or appreciate getting this type of information on my desk when I arrive. So if you could please get it to all of us in advance so we have a chance to actually look at it ahead of time, that would be greatly appreciated. I know by me, I can't really speak for all of them, but yeah, I like to have things in advance so I'm not sitting here trying to digest it with 5 minutes to spare. And thank you for the
that was my fault. I was the one that had done that and told her to bring it at this meeting instead of sending it sooner, so that was my fault.
Well, I'm glad to have it. It's just that if we're going to be looking at it, I prefer to have it at least some advance so I can look at it and know what I'm looking at. So, and otherwise, thank you for the report.
Has anything been spent between, because this only says only till 12/31/2024, has anything been spent this year?
No.
Like the chiller will be done this year. They're working on that right now, so that's going to be one of the big ones. Yeah,
we
nothing
haven't
in January.
spent anything in January. But there's some I know that's being paid in February. There's a couple I know, right, like the building in February, March. So yeah, nothing in January.
Any other questions or comments? Now we move on to the CNO report.
Thank you. So for the CNO report, This report is a template I use at each time to report to the board, so if there's any other information that you would like to see that's not here, please let me know and I can gather that for you. Otherwise, this is the template I will be using. For the transfers, we had a total of 1,050 transfers between January and November. The data is we're a little bit behind on the data due to now that we have Cerner, it's a little bit more difficult to gather the data, so we're trying to get caught up. Hopefully we'll be caught up pretty soon on it, and we can provide all of 2024 data. This is very typical of other months. You'll see that cardiology, GI, neurosurgery, neurology, and pediatrics are usually our top services that we transfer out. For cardiology, usually patients that are needing interventional cardiology, those services we don't have here. GI is usually they need ERCPs, advanced critical care for GI patients that we don't have. As far as services, we don't have those here, and we don't have a neurosurgery area, so those get transferred out. And pediatrics, you said that we need to keep our babies here. A lot of the patients that get transferred, we keep a lot of like the respiratory, GI kind of stuff, mild, that we can take care of. But patients who, we're at risk of deteriorating, where they would need like ventilation support or other services, those get transferred out. So that's typically what you're going to see. In the past, we usually transfer most of our patients to scripts UCSD. I have observed a trend in the last couple of months where we've been kind of moving from those two healthcare systems to desert. And the reason for that is I talked to the ER medical staff is that for some reason, I don't know if Desert Regional is targeting us or what, but they have been more easier to work with and then the timeliness as far as being able to transfer patients who are time sensitive as far as their transfers, it's just much easier. So that's the reason why in the last couple of months we've seen an uptick in transfers to Desert Regional versus UCSD or Scripps. Even though we have the Scripps affiliation, they've been struggling because, for example, GI, they've had some issues as far as coverage. And so they've been struggling there, and they haven't always accepted our patients because of lack of that. So that's the transfer piece of it. Do you guys have any questions regarding the transfer report?
So for me, I would like to see like percentage of patients that are transferred out.
Okay.
So like your total, right, and then patients transferred, and then your total number of patients, to see what percentage.
So are you talking about like number of ER patients that come in and the number of those patients that get transferred?
Yeah.
Okay, I can do that.
I think that's a lot.
Okay. All right. And then, so for leadership updates, we do have Nicole Castañeda. She's one of our nurses here. She's been here for many years, over 20 years. She has a BSN. She's taking a full-time position as our nurse residency coordinator. This is an important position because this person helps coordinate all the work that has to happen in order to onboard newly hired, newly graduated nurses. She keeps track of the 2040 program, and she helps with recruitment efforts when the IDC or SDSU, when they're going to have graduations, we do special events for them, and she helps with to support that. So I just wanted to include that here. We're pretty happy that we're going to have her as a full-time because it's a lot of work. Okay. And then you can see there the staffing. If you have any questions regarding staffing, you can ask me. We do have travelers currently. We do have, we've been having travelers since before COVID. I think at one point we were over 20 travelers in the OB area. We've gone it down to where we've consistently kept it under 6, but we do have the need for travelers in the OB area consistently. In Med-Surg, we did not have any travelers for some time, but when the busy season started, we did have a need for them. There's 4 of them. It's just one assignment. Traveler assignments are usually 13 weeks. And so we're expected, their contracts will be over sometime in April, and we're not going to be renewing them. So we'll be able to get rid of those travelers. And there's one for emergency department that just started, and that's a 13-week assignment as well. And then just some notable updates. Go through each one or just would you like me to go through each point, or do you have questions regarding? Okay, so for patient experience, our overall score is 69%, and that's below our 50th percentile. And then I added, some of the areas that we're focusing on: communication with nurses, doctors, care transition. The reason why I added this piece here is because it is one of our strategic pillars that we have been focusing on. We currently, this is below the 50th percentile, and our goal is to be at least above the 65th percentile. So that's something that we're working on. We have a patient care team. We meet every other week to talk about strategies that we could put in place to help improve patient experience. We are going to transition from NRC Health to Press Gaming. This is the company, I guess you could say, that helps administer the HCAHPS survey to our patients. And so that's going to be done in over 6 to 8 weeks. So we're pretty happy about that because it's going to include some eye rounding, which, with tablets technology, we'll be able to collect data on the rounding that happens, and then able to report it, and then look at strategies of how to make patient experience better. And then we also did that, and we were able to save some money, so that was an extra plus. The Patient Safety and Employee Engagement Survey, that's an annual survey that we administer to our staff. Medical staff is also invited to participate. They don't always. I think there's always less than 15 that participate. But that staff does. We always have a goal. Our goal this year is to be over 85% as far as our participation rate. And it focuses on employee engagement and patient safety. And we've been doing it since 2017, so there's a lot of data there that gets collected, and we can see over time how we're doing, if we're doing better or worse. And then off of that survey, once we get the results, we communicate it to our departments and then start developing, what can we do to make improvements.
I do have a question. So with regard to the patient experience, so do you provide patients a survey card or something? Or how do you gauge that?
So we have, when they're here, we have cards that our patient concierges give to them, and we tell them, if you have, someone shined and someone did something really great that you like to point out, here's a comment card. We provide comment cards. However, the HCAHPS survey, that's different. When they are discharged within a certain amount of time in the mail, they get a survey. And it's a set number of questions that they get that hopefully they fill out and they email back to us.
And what is that survey, what type of questions do they ask?
They ask questions about, it's different questions, but it's like, would you recommend this hospital, to others? Like from a 0 to 10, how likely are you to recommend it? They ask questions about.
I'm going to mention too, because I was here not too long ago, utilizing the service. I think I either got a text message or a phone call.
That was if you were in the ER or in the outpatient or the clinic. Those they can be done that way. But on the inpatient side, CMS requires currently that it gets done via mail. Now we're going to be able to do it via email as well, but still no phone calls or texts.
And there are specific questions that are asked
Yes.
for all locations.
Yes.
It doesn't matter
It's the
where you
same.
go to, it's the same thing, because they post those scores out, and that's how we have that data. So if you went to this hospital or any in San Diego or any in LA, you would get the same questions asked.
You can add questions. Like at one point, our survey was like 3 or 4 pages long. And then the executive team got together and we're like, no, we're gonna make it shorter because we felt like if it was shorter, if it was just the questions that were required on the survey, then it would be more likely that they participated. So we did that. We can add additional questions, and right now, actually, with going with Tuscany, we are supposed to see if we want to add additional questions to that survey. Kind of forgot where I was at.
I just asked about what questions were on the survey, but I would like to see a copy of that survey at some point.
So it's not administered by us, so we actually don't have the survey, but someone who has been here as a patient, they may have it and they can share it. I can see if there's like an example of it like online and kind of show you, but we actually don't have it because we don't administer it. And we're actually not supposed to, we can talk to the patients about like, hey, when you go home, you might receive a survey in the mail, it would be really helpful to us if you filled it out because it'll help us make improvements, but we're not supposed to talk to them about what questions they're going to ask or show them the survey. That's not permissible.
It's all administered by a third party.
Okay, and then the third party gets back to you and say, hey, these are the
Yes.
scores or what have you.
Yes. And I have a copy of one that I brought just in case you ask me something specific about it, but I'll leave it here, or I'll send our latest one with our fourth quarter data. I'll send it.
I have a quick question also, just so I understand the survey, the scoring here. Like, for example, it says overall score is 69%, but below the 50th percentile, does that mean as a whole, everybody that's being surveyed, we're below the 50%?
Yes. Yes, so for example, for the overall for fourth quarter, we were at 69%, right? The 50th percentile is 72.9. The sample for that is 337 plus responses. So,
The reason I ask about the survey is because if we're, our concern is that we have quality healthcare, number one, right? And sometimes that involves the patients not being satisfied for a variety of reasons. And how are we as a district going to know whether they're not satisfied about a certain specific issue if it's not covered on the survey? So say, for example, say they have a complaint about the way they were treated, customer service from the doctor or a nurse or some staff member. How are we going to know that, hey, we need to make improvements in how we treat patients, make sure they have a great experience? You know what I'm saying?
So we have a process for that. It's our grievance process. So there are ways for them to be able to voice their concerns or grievances in real time while they're still here. They're also very good about mailing or calling to voice concerns after they've been here. It's posted also on our website on how they can file a grievance or a complaint. And also too, like I said, we have comments over that time, 30 days, then we send them another letter that states, it's taking us a little bit longer. So we're going to need additional time, but we're going to let you know, what the outcome was. So there's multiple ways that we can find that out.
Thank you.
So the nurse residency program, just kind of sharing with you the amount of new nurses that are going to be coming in. These are new nurses. A lot of them, this is their first time, employment. So we have a nurse residency program to help support them, a new preceptorship program to help support them, that we're going to be doing more things to strengthen it. Case management, that's just data there that may be useful to you as far as our average daily census, our acute case mix index that just tells us, how sick are our patients, because then, the sicker they are, the more services they're going to need, maybe the longer length of stay. It's attached to reimbursement, so we like to see our case mix index greater than the 1.4. Some will tell you that it has to do with documentation and reimbursement, and others will tell you okay, this is how sick our patients are and whatever. So average length of stay, acute case, all-cause hospital-wide readmission. That's just patients who are readmitted within 30 days, and it's all causes, like all diagnoses. So we tend to look at that. And then we've been doing over the last few years a lot of work as far as our ED throughput, so I like to include that in there. Our average daily visits, how much time on a median it takes for triage of patients, and then the length of stay for the discharge patients. I know sometimes, on social media they'll say like, oh, it took 6 hours, to get out of there. This helps show you, it might have for one patient, but might have been an outlier. That's not the average or the usual. And so that's kind of where we're at there. The Da Vinci Robotics, that's a new program we started in July. We were 99 cases in 2024, one short of 100. And in January we did 20 cases. So I think that's the most important stuff. Again, if you have questions, I'd be happy to answer them.
I do have one question.
Sure.
Really quick with the nurse residency program. It says 17. Is that because we're limited by a certain issue that we can only have 17, or is that like part of the program? You only get 17 at a time.
We kind of have we had kind of said, okay, we're going to try and keep it at 15, but it's not official. We could go over the student nurse interns, they're students. And so on the pay period, they do 2 shifts and they're shadowing. What the goal is that they learn our environment, they learn our procedures, they get to know the staff, the doctors, and so they'll be more willing to come and work for us once they graduate. And it's been very helpful. The majority of our student nurse interns do stay here and then become our newly hired nurses. It's only 1 or 2 that we lose, and it's usually because they move out of town. And what we've noticed also, like when we're trying to recruit the new graduates, the ones that go to ECRMC, the reason why they went over there was because they started a nurse residency program over there, or they did their clinicals over there, and so they got used to that organization. So it's a good program to have.
Thank you.
Mm-hmm.
Do we offer debt forgiveness for the education if they come to work with us?
No, we have this. So our 2040 program, if they work 20, so I know. They laugh because it's 2040 program, but they're not actually working 20 hours and getting paid 40 hours, and you have to really have fun with that. So I laughed. So they work set amount of hours, and then they get paid for 40 hours, and so that helps them, like with school and be able to study, and then also be able to work here. Some of them, when they're in the 2040 program, they are in the departments where they wish to go work, but some of them go to different areas. And so they're in the 2040 program, and they're agreeing to, when they're done, that they're going to pay back those hours that were, given to them during the 2040 program. So usually, they were in the program for 2 years. Usually it's the last 2 semesters that they're in the program. They'll be paying back those 2 semesters. But we don't have a forgiveness. We don't have that.
Thank you.
Do you have any other questions? Thank you. So now we'll move on to Human Resources report.
Good evening, everyone. I would like to speak to the question you asked. The end of last year, we brought back a education reimbursement program. So we did start a program that if you work for us for at least a year, you're in good standing, you have the ability to get $5,000 a year of your student debt, like we pay to you, and kind of like a ransom. So we are, as part of the retention,
with our retention and our engagement, we are starting to branch into things like that. So we do have some hope.
Thank you.
My report is kind of simple this month because realistically, I wanted to know as the board what information you would like to see from HR. You can see I've outlined for everyone how many new hires, how many jobs we've offered. I would like to speak to terminations. Termination sounds very scary, but those aren't all involuntary. Those also include voluntary, so people who have left. So for the month of January, you'll notice that although we did have 18 terminations, all of them were voluntary. So we didn't let them go. I kind of outlined for you what the HR projects are for 2025 that we're working on. Kind of outlined how many employees we have in each of our benefit plans, students, open positions, and then kind of gave a summary of what we have for employee health and workman's compensation. So I guess I'll start with asking the board, does anyone have any questions about the HR report?
Is there a way you could put like your retention rate and then the average like length of employment?
I can, and also, I forgot to put it in this one, but the turnover rate, and what our turnover rate is compared to some of our hospitals close to us, to our turnover rate. As far as a comparison, I thought maybe that might be something you guys are interested in as well. So I kind of agree with Carol, if you have suggestions and things you'd like to see from an HR standpoint, please do let me know, and I'll make sure that I include those in the reports moving forward.
Do you do exit interviews or exit surveys?
We do, and I've actually got that set up now. When we terminate an employer, an employee gives a resignation, leaves, in ADP, it triggers when the termination status was that it sends the exit interview. So employees can actually do the exit interview after they've left at their home, on their home email address, and you get great feedback that way. So
How often do you review it?
I usually look at the exit interviews once a month. I actually just look through our exit interviews and we address if there are problems. Sometimes employees just say everything was great, and other times they give numbers, but they don't give any comments, and it just kind of depends. Anyone who leaves comments, we will discuss the interviews.
And you analyze the departments that they come from, their comments?
Yes.
I've got a couple of questions. So is this district, so for example, say you're a nurse and or an employee, and you reach a certain amount of years you've been working here, do you guys get like an incremental percentage increase in your pay, like a type of seniority pay for employees, or no? Or you just get regular raises with no seniority pay? Like say you hit 18, you get 1% extra on your pay. You hit 19 years, you get 2% extra on your pay. Just as an example.
No, our salary scales are set to where it's stepped out to how many years. So let's just say our salary range went from 25 to 29. Once you hit the end of the salary range, you would just be given lump sums every year in lieu of the 3% increase as it went. But no, we at this time do not have a special 3%.
How do you arrive at how much the lump sum is? Is it a percentage, or how do you figure out what that lump sum is going to be?
So our policy is that if you are stepped out of the salary scale, then you would receive, say the district, say you guys approve a 3% increase when we bring back the increases, then that person would receive their lump sum in lieu of the 3% increase. So they would get the 3%, but they would get it then, rather than be added to their hourly wage to keep compounding every year. You would just stop until the scale moved up. Does that make sense?
My other question is, as far as outreach, what type of outreach are you guys doing to be able to bring in, like, for example, the nurses, again, going back to that, what IVC, career fairs, what is it that you guys are actively doing to recruit?
So we do. We go to the career fairs. We have a retention and recruitment coordinator, and she goes out to the different job fairs and different things like that. We've also expanded to where now we're advertising outside of the valley. So now we're actually looking in different areas outside of the valley.
And when that recruitment person goes out to these fairs, do the employees have a chance to accompany them? Like, so for example, say you're there and you have somebody in one department, pediatrics, that's there with you, and people start asking questions, and they're like, hey, I want to have a question about pediatrics. You have that person there to answer those questions. Or is it just that one person that shows up and answers all the questions?
Sometimes the department directors will go. Let's say that the job fair is geared towards nursing. Generally, a couple of the nursing directors will kind of show up so they can kind of do the on-site interviews with Marcel and Michelle.
And those other employees that just are tag along, basically, to help out, do they get any comp time or anything like that, or are they just doing it on a voluntary basis?
No, these are done during
During
work
work
hours,
hours?
so they're actually being compensated like, from work.
Gotcha. That's all I have. Thank you.
Do you have any other questions from the board?
Thank you. Thank you.
Thank you very much.
Now moving on to item 11A, policy and procedure, standardized procedure for registered nurses, administration of prescription, medication, and other routine orders. Huh?
These are not new, are they?
No, they're existing. Do you want me to comment on each one of these policies? Like, kind of tell you a little bit about what they are, or?
So, just real quick, one thing that I'll tell you guys as board members, so that you're aware, each one of the policies, the sections are all the same for every single one of them. And when we do these, the one that's going to be the most important for you guys as we do renewals or the annual reviews is section 8, because that's going to tell you what changed, if there were any changes to it or not, and it'll tell you right there what that is. So that would be what I would tell you to look at, because in most cases, you're not going to be experts on anything in this policy and procedure, but you'll be able to see what changes happen, and if you have questions about that, you can ask them at that point in time.
Is this something we would just want to put on the consent agenda?
You can do that for all policies or whatever as they come through. Anything that's a renewal, you can do that, and if it's a new policy, you can ask that pulled out or something like that.
I do have one question now. At some point, this is not going to be Pioneer's Memorial Healthcare District. It's actually going to be the Imperial Valley Healthcare District.
We should do a lot of work this week.
Yeah, so all of these that are in here will be the last time that you see that, because they were ones that were approved through their committee before to come onto that. So they didn't get adjusted before they came here. But I did have conversation with a couple of board members about that, who had the same concern. And so as you guys go through and make a motion to approve these, you can do it with that caveat that those are changed. And then on our end, we'll change it, and then it'll become effective with what you guys have just put in there. So.
Okay. Thank you.
Do you have any questions about this policy?
Chris, one question. So these policies here, if and when we take over El Centro Regional, are any of these policies going to impact or have to be changed mandatorily when we absorb El Centro Regional, or are these policies that are going to hold up whether we have them or not? Because I'm assuming that there's probably other policies
Correct.
that will definitely
Yes.
change for sure,
Yep.
because of licensing or what have you. So these policies here, we're good to go.
Right, and so some of these may have the potential to be changed. Most likely, some of them will. The procedures portion of it will probably change just because it's specific to location and equipment. And so we would have to make those. But as we do our reviews, like the annual, if we waited until we had ECRMC fully in and we were past our escrow period, then these would be grossly outdated and we would be following our own policy to review them annually and approve. So some of them will change and some of them won't. Some of them are going to start very specific to this portion of it. But in the end, when all that happens, when all that comes together, what you guys will see will be, a coming together of all of this stuff. So this very policy that you're looking at right now, well, maybe not that one, but animals permitted in the hospital, for example, that could see a change because there could be something in ECRMC that they do a little different. We want to incorporate that, or vice versa. And so you would see something like that, and it would also be specific when you start looking at some of the location. Like some of them are going to be district-wide, so it doesn't matter where you're at; it will apply to every location. Anti-bullying, those type of policies. It doesn't matter where you work; those are all going to be the same. Things that are like this with the SART procedure or any of the blood pathogen exposure protocol, our policy will be the same, but our procedure might be a little different in each location. So we'll have to adjust that to reflect if you're at this clinic, you're going to do this. If you're in the ER, you're going to do this. If you're, those type of things would be things that could potentially change that would happen with all of us together. And the idea would be that we would take all the good things from all of that and put it into a much better policy that works for both of us at that point in time. So it would be better policy all the way around.
I don't know if you know this, but Pioneers is the only START program for the county.
And you might want to tell what that is.
So the START program is it stands for Sexual Assault Response Team. So we have a program here. So anyone who states that they've been sexually assaulted, those patients come here for their medical legal exam. They get treated, and we provide services. And so we're the only one in the county that does that. We have 2 nurses who are on call 24/7 for that.
I'm surprised that you guys are doing
It's a tough thing. It's tough to get the certification. So
Yeah, it was a decision that was done like in 1994 or something.
Carol's
I
one of
would
those
say
nurses
I read
that's
on
on
your
call
bio
that.
that you have. I said I read in your bio that you have it, so that's why I'm surprised.
Yeah.
That there, you know what I mean? It must be like super hard to get. There's only 2 in the county.
Well, it's just hard. The training's hard, and just to get nurses. Over the years, we've trained nurses. It's a long process because we require a lot of things to be in place because we're working on our own by the use of protocols, and so the training takes a long time. So usually, what happens is you get them trained, and then then they have to do a certain number of exams on their own, and then by the time they're done and good to ready to go on their own, like they decided to move, and so we lose them, and it's just been hard. People come to me and they say they're interested, and then once we talk about what the program entails, they're not interested anymore. So,
Seems like it'd be a hard one.
yeah.
It seems like it'd be a hard one to handle.
It's fun.
So do you do those, like, for example, when you have incidents at the prison and jail as well?
Yeah, so we cover adults 14 and over, and we service the CDC and Naval Air Facility and ICE as well. And we do victims and suspects.
I have a procedural question.
Yep.
Since A through M are all policies and procedures, do we want to go through each and every one of them, or can we make a motion to approve A through M? Or
Someone can make a motion to approve items 11A through M in one fell swoop, and that would be fine.
okay. I don't want to take away from anybody if you have any questions, but it seems like it might be a little bit tedious, and we did get these in advance to read, so I don't wanna take that away if you have any questions on anything else, but I would.
Go ahead.
Okay, no, go ahead.
I'll just a quick question out of curiosity, when going to COVID deaths, when it mentions 977 deaths in the valley, is that just in the valley, or if a valley resident was sent somewhere else and died there, are they counted as 977?
Are you looking at the infection
Yeah.
plan? I would have to go back and ask Angela, our infection control nurse. I know that the county was keeping numbers, how many deaths occurred here, but they were also keeping track of when that happened elsewhere. So I need to find out for sure what that number is. So I'll email her and I'll get back to you on that.
If there aren't any other questions, then I would make a motion that we go ahead and approve item 11A through M, the policies and procedures as listed.
I'll second.
I have a motion by Gitzel and a second by Garcia. All in favor, say aye.
Aye.
Any opposed? Any abstentions? Motion carries. To item N, authorize a professional services contract consulting services with Progressive Healthcare Incorporated.
This would be a consultant that's going to help with a couple of the CHOWs that we have. I guess that's probably about a week left to complete. I can yell.
No, you're good.
Okay. They've already started on the work. We already have another agreement with them to do other work, but we would like to keep the CHOW work that they're doing separate and not kind of go into their other agreement. So that's why we decided to bring this to the board to allow us to have this outside consulting company help us with all the documentation that needs to get done with the CHOW.
Maybe can you, yeah. I don't know if
Two can be on at the same time.
Yours and this one cannot.
Oh.
So the rest of them.
And just for the board's information, there is a policy since we adopted, this board elected to adopt all of the Pioneers policies. There is a policy CMP 0003, section 4.3.2, that requires all consulting contracts, regardless of amount or type of compensation, must be approved by the board. So that's one of the reasons that these consultant contracts, and there's a few on the agenda, are being presented to the board for approval.
Can we make a revision? I would say I see contracts for like, without, I'm like, why is this, so that's why.
That's why.
It seems like it just really impedes upon your work. I see everybody shaking their heads, so it's not good. So if we could get staff to bring back a policy to make it, you guys can do your job and we don't have to micromanage, that would be great. But with that,
Okay, I guess I did have a question. I don't want to micromanage, but I do like it when, contracts that are binding us, especially when it says budgeted no. And also, there's no review by legal, so I don't know if Adriana had a chance to look at it, because I know from the IVHD standpoint, we have a lot of consultants and people that have been working behind the scenes, and I just want to make sure that this isn't a duplication of something that's already happening.
So what I'll recommend, because this is really a fast-moving issue with the change of ownership, with the licensing, the regulatory issues that staff is facing right now, is approval of the essential terms, which is on the agenda packet, which is the hourly rate and the sort of scope of work they'd be assisting with. And what I would do is use the sort of professional services agreement that we have used for other consultants that I have reviewed, and have Progressive Healthcare and the other consultants execute those professional services agreement or consulting agreements, because I will review those prior to recommending execution. I think the critical thing for this type of approval is the sort of key terms which are on the agenda and in the packet. And you can also set, for example, not to exceed amounts if you want to control a ceiling. That's not included here, but you can if you like.
do a cost estimate. Or is it, I mean, something I think most haven't done before, so it's kind of nice.
On the
Yeah.
line here, so.
Yeah.
So that's why, like, so that's why you'll see like, the WIPD contract that's in there. It's part of this, but it's a completely different section of it. It has a cap on there, so if we're gonna exceed that, if they say they're gonna exceed that, pretty much like we've done with BRG, then it'll have to come back to the board to approve to go over that dollar amount that's in there. Because we don't, like, this is the way that we're doing this with this chow and with what we're going to do with the RHCs, in particular, hasn't been done before. And so there's some unknowns that would make it difficult for anybody that's going to put anything in there to say, we can do it for this amount, because there's components of it that we'll run into and be like, okay, we didn't know that we were going to have to do that, and it's going to be X amount of hours and so forth. So,
Is this something that Cooper Lundy is consulting with?
yeah, they're working with us on it as well.
Are they working with them?
Yeah, they're part of the whole group that we have, the chow group, that,
Because I have concerns because these people are from Tennessee, they're not from California. So do they know all the California laws?
yeah, Rick is very familiar with California. He does a lot of stuff for districts in California.
And he knows the deadline?
Yes, yep.
We'll actually be here next week to sit down with Chris and I so we can sign everything.
Yeah, I think I would need a time.
So we've been meeting a couple times, and the issues presented by the transition from pioneers to IVHD are significant and super complicated, because there's rural health clinics which differ from the hospital license, and a lot of these folks have expertise that I don't have, and that even Hooper Lundy doesn't have, because it's really particular. So it's just getting sort of all the specialties together in a working group to make sure the ball is not dropped, and Carly and Chris are doing a great job managing it. So my only recommendation, if you are inclined to move forward with this, would be to authorize a professional services agreement instead of just execution of the proposal, because the proposal is just, sort of 2 pages, and we would want to make sure, the other kind of standard terms that are in our PSAs are in this consulting agreement also.
Do you have any other questions for the board? No motion?
I guess I would move to approve professional services agreements. Is that what you said? That we could put that into our standard form?
Yeah, I would say authorize the proposal for consulting services from Progressive Healthcare subject to execution of a professional services agreement. So we'll just attach the proposal as an exhibit to the PSA.
Okay, I make that motion.
Okay.
All second.
I have a motion by Goodsell and a second by Garcia. All in favor, say aye.
Aye.
Any opposed? Any abstentions? Motion carries. Now we'll move on to item number O, authorize the UCSD telemedicine services.
So this one in particular, we have, we need obviously intensivists in our ICU, and we have a great one that works for us now, but we can't have them 24/7. And so this allows us to be able to have coverage for those services via tele, and that will be on the Fridays, Saturdays, and Sundays that he's not available when he takes his time off. So that would be what that's for. It also has a medical director piece of that component that's included in there. All in all, the service will probably, there should be looking at about $6,000, $6,044 a month is what that would run us to be able to have those intensivists during that time, which would be a huge help, obviously, for our staff, but also for folks in the ER as well, as they need somebody to consult with to see where they're going to place patients.
I have a question. On the medical director services, who will he be directing?
The tele group.
The television?
Yeah, it's just for the tele group.
signs all the help us and stuff.
Yeah, yeah, he's the one he's the one that'll set it up on the tele side. Yeah, on the tele side with them. This is also the same service that is used at ECRMC right now as well, so if you mention those same programs.
And you were doing the billing? We are doing the
Yes,
billing?
yep.
Okay, so it's kind of a wash.
Kind of a wash, yep.
Yeah, okay. Because I know that $210 is for the 35 to 75 minute reimbursement for.
Right. And it's going to do about 6 hours, so 2 hours each day is what they're anticipating. So for Friday, Saturday, and Sunday, 6 hours total, and then the one for the medical director portion of that, it has a cap on number of hours in the year, which is 60, which roughly comes out to $1,000 a month for that.
And then UCSD is 3 publishers.
Right, there are a fee on top of that. That's why it's like $6,044 or whatever, $244 a month. Basically.
And they have their own malpractice?
Yeah, yep. And so right now, this was one that had already been approved previously, but they made a few changes to it. And so I wanted to bring it to the board to give you guys the opportunity to see it and approve it. And then also, once this is signed, then they'll be able to provide that information to credentialing, and the credentialing will be able to finish them up, and that will happen in March. And then we can start the services soon thereafter, after credentialing is finished.
And will they represent themselves at the NEC or give a report or anything like that?
They probably won't do something like that. I imagine we could probably get him to do that from time to time if we needed to, like when we do some of the quarterly pieces. He could probably at least provide the report and potentially show up. I mean, he is the medical director, so we should be able to get some of those services from him.
He's already met with Dr. Nelson. He's already done some education with them, and he's already promised to help us with some policies and procedures in the NCU. So I think if we ask him, he would be really great. Thank you.
I just want to point out there's a typo. It says telemedicine service.
Yes.
And the other typo is the date. You have 2024.
Oh,
And then also in the agreement, it still has Carly as CEO.
yeah, that's the one that was done. When we print it out for signature, we can change that on there.
Okay. And then since this one doesn't need to be amended, let's say if you're a Valley Healthcare District or.
So my quick question is, it says reviewed by legal, but I don't think this is not the same transfer agreement or affiliation agreement. I don't think we had reviewed this, right?
No, Sally did.
Okay, so just want to clarify that. Our firm didn't have a chance to review this. I think, that's FYI. And the contract that is in here is the contract that's currently in effect that we would just re-up, or?
Well, it's not in effect yet.
Okay.
They made it. There was some minor changes. It was July.
So they had approved it, they had Chris's name on it, so we asked them to change with our name when we were going to start to implement.
So I could sign it, but then they made language changes to it, so then it's like, okay, Sally, recheck it to make sure if we have to go back to the board. Chris came back on, came back.
I would feel more comfortable if we had Adriana or agreement. I would feel more comfortable. Honestly.
You can move to approve subject to legal's revisions. Like once we have a chance to look it over and finalize a negotiation with UCSD, if we have revisions, then we can move forward with it, so long as the revisions are not substantive, like a major change to the contract value.
Is it better to do it that way than just table it until you have a chance to look at it?
I don't know what the time, if there's a time pressure, then we should, if there's a time pressure, my recommendation is to approve it now subject to the legal review. If there's no time pressure, then yes, that's a good idea to bring it back once it's
We've already done everything on the back end. The credentialing is just literally waiting for this so that they can do it. And the providers and everybody else are waiting for it to be able to come into effect to help them with that as well. Yeah.
I would make a motion that we go ahead and approve the telemedicine services with UCSC subject to legal review and approval.
Second.
I have a motion by Vincel and a second by Proctor. All in favor, say aye.
Aye.
Thank you, Nora.
Any opposed? Any abstentions? Carries. Now move on to item P, the organizational chart.
So this one is just updating our org chart to the way it is currently today. It's going to be required for the CHOW, and so we need to have an updated one. Our other one was pretty old, and so we just need to get this approved. We had the team went through it to make sure that all of those other sub areas were appropriate underneath those folks, and then that's what's been sent to you guys.
Do you have any questions?
I make a motion to approve the organizational chart.
I have a motion by Garcia and a second by Berger. All in favor, say aye.
Aye.
Any opposed? Any abstentions? Carries. Item Q, authorize confidence consulting. So this is actually something that I brought. I don't know if Chris wants to. I mean,
I can speak to it if you want to. Essentially what this does is it's a board training for you guys. So this person in particular, we looked at other options for the board training, and this person in particular has a great resume and has done this quite a bit, and it gives more of the rounded approach on what we want to be able to do for you guys to offer that training so that you have a better understanding of your role and feel more confident in some of the things that you're doing as well. So we want to be able to provide that to you. And this, I didn't do any of the work on this. Katie did the work on this. We just went through and set it up to be able to bring to you guys.
I would say, so this, so obviously the session's scheduled because I was like, we're not doing a board meeting and a training on the same day. This will be a few hours in itself. So just a little bit of background. Jeff Mills is a former CEO of Scripps La Jolla, and he now does consulting on governing bodies to teach you how to be an effective governing body, how to make sure the boards get along, to make sure, obviously one of the things, he's eyes in, hands out, and teaches everybody just really what your role is as a board member, what your role is as a governing body, and I think it's something that's really important for our board to know how to be a good functioning governing body as we are taking on all these organizations. And so I looked at, plenty of other, there's ACHD has a governing training, but it's a webinar, right? Like, I hate webinars. Other ones that I found that were similar to this were, I know that it were like 3 times the amount. And so, but yeah, I think he's really good, and it's something we can work through, and then he has other services, but once you guys meet him, we can kind of tailor on exactly what we want to set up with him.
I make a motion to approve the confidence consultation contract.
Do you want to make this a professional services agreement as well?
Schedule
I would say this falls maybe more under like a general services agreement, especially in light of the amount. What I tend to do is advise for contracts that are less than, say, $25,000. You don't need as intense kind of language, but we can definitely draft something up that's appropriate. Yeah.
So a motion by Garcia. Second. And a second by Berger. All in favor say aye.
Aye.
Any opposed? Any abstention? Motion carries. Now we'll move on to item R, authorize the Association of California Healthcare District contract value.
So this is for the ACHD, as Katie had indicated. They are specifically set up for district hospitals. Well, districts, I should say, because some members are not hospitals, some districts don't have a hospital. But they do a lot of training. There's a lot of opportunity to collaborate with other districts. They do a lot of the lobbying for things that are very specific to district hospitals, and working with us on that. They do an annual meeting that has opportunity for board members to attend and get some training there, in coordination with our staff as well. So this one in particular, initially it was $30,000 was what it was going to be. I had a conversation with Kathy about it and our situation, and we got it down to $8,600. And you can see that how they came up with those numbers after that. So that's the recommendation for the board at this time, to approve the dues for the ACHD, which will take us through June of this year.
So say your name is spelled wrong. Christopher, that's your last name. But do I have a motion to approve, or any questions by the board? I think these are one of the things where it's like, if they're not going to get in on just our specific district's needs, they're going to fight for everybody's. And it's one of those, if our, we have to be at the table. Well, I've also, there's a bunch of trainings on there where I've been actually, asking our CEO, can you give me a login for this? And he's like, we got to pay our dues. And I was like, well, I want to watch this training. So.
And they do have a certification program, just so you guys are aware, that will certify the district, and it has a checklist of things that if we do these things, then we can become a certified district. I believe it makes our dues go down and some other things like that as well. But it's a little bit extra work for us to do that. Personally, I think if you're going to be part of it, then you should do that, because that's the right message.
And you also have the opportunity to set on their board.
Yep, exactly.
And they also have annual meetings and conferences that have really substantive training sessions that the boards can attend. Sometimes some of the sessions are geared towards boards that are really educational and great, and you could go and get reimbursed for the expenses through the reimbursement policy. So it's something that's in our benefit of ECHD.
And it is, to that point too, as I mentioned too, it allows that to happen with our staff at the same time. So there will be things on there that are very much board specific that you would go to, we would go to a different portion of it, but then they have some that are together, which I think are very helpful.
This is the primary association in the law, if I'm not mistaken, right? This is
For our districts, yes,
Yeah.
absolutely. There's one that's a little bit more primary, the DHLF one. That's where we get our money from. That one helps out quite a bit on that reimbursement side. So that might be primary from that standpoint, because it helps us with that. But yeah, overall with all the other stuff, this one is definitely a good one to be part of.
I make a motion to authorize the ACHD Association of California Health District contract.
I'll second.
I have a motion by Garcia and a second by Goodsell. All in favor, say aye.
Aye.
Any opposed? Any abstentions? Motion carries.
So now-
You opposed?
Oh, no, I should abstain.
So now we get our own logins once we hear these.
We'll get you guys taken care of there.
I have, so it's been actually a while. I'm like, do we have a login for this I can use, please? I was like, is there a company one? I want to watch this training. I think it's important, so. We'll move to item.
I do have a question real quick. I noticed at the bottom it has recommended action 01 compliance officer 3/2023. I just saw that right now. And then I looked back at the previous item, and it has the same thing at the very bottom. So I don't know if that's like a footer.
It's like the form number, for the form. Because this is
Okay.
a board item.
Okay.
Yeah,
All right. And then that.
correct. It's a footer, just think.
Okay. Thanks.
And again, I don't think I put it in any of my motions, but you are going to be changing this over to Impro Valley Healthcare
Yes.
District.
Yes.
We'll move on to item S. Authorize Woodley.
Yep. So it's what we had talked about earlier as far as they're going to be helping us on the RHC side, which is definitely one that's a little bit more tricky than the rest of that. And these guys are subject matter experts as far as that stuff goes. So we're definitely relying on their help to help us to wade through this process. Because, as I said, the RHC one is very sensitive because we want to maintain our RHC statuses and so forth. And again, nothing like this has been done before. And so we have to make sure that we're going to do this right so we don't lose those.
Same caveat, I definitely concur with Chris that this is a good idea, but the review by legal is not me. And I do recommend if the board approves the proposal to do it subject to IVHD's PSA, because for example, in their terms, professional services terms and conditions, the choice of law is Illinois, it should be California, etc. So we should just sort of clean this up with our PSA language.
And there's 3 typos on the front page.
It says on the agenda it's with fleet, but it's with flash.
Yeah. Oh, so there's 4. Because it's rule, and
Yeah.
then there's an R, and your name's still wrong.
Yep.
So
We're just making sure you guys are paying attention.
typo striking words, like I think, yeah. So, do you have any questions by the board?
Did you have a conversation with them at all?
Yes.
Okay, because you know where there's a lot of non-enrollment.
Yes. And that's the issue.
That's the issue.
Yep. So most likely, one of our best course is going to be to get a waiver. And so they're going to have to help us get that waiver, especially because this was done by law. So
Yeah, they were grandfathered. So
yes. Yeah, so,
hopefully we keep that status.
yes. And so the same thing that will happen as we go through this process, that will set the stage and the ground rules for what will need to happen when we bring in ECRC, because they're in the exact same boat.
Right.
But worse than
Yeah, I think that
so.
we're the only one that's still enrolled. Okay, thank you.
So I make a motion to authorize the with flag, with fleet contract, subject to our legal approval.
Seconded.
I have a motion by Garcia and a second by Prompter. All in favor say aye.
Aye.
Any opposed? Any abstentions? Motion carries. With that, move on to item 12, urgent care update.
Well, earlier today, there was a grand opening for the urgent care in Calexico. For those of you that would thank you. Chris, our CEO, was there. Mr. Rondez, Nola, and Mr. Proctor. And for those that haven't been able to, still want to go, let me know we can arrange that. The only issues that came up today, the north end is done, but the south end, we have a couple of issues that a new inspector went, and issues that are beyond code. So luckily, Mr. Valdez presented to me, introduced me today to one of the city council members,
If you look last week.
Gillespie, and we had a long conversation, and we're going to set up a meeting and a walkthrough for next week with the inspector, that actually the lead inspector, who told us to make those changes, and now we're regarding. So we'll get that clarified early next week. I'll keep Chris in the loop, and I'll keep you posted. But everything else that went at the event was very well attended. There was a lot of media there. Thank you for those who spoke to the media. And actually, it's a big win for Calexico, because I want to thank Mr. Valdez and the Heritage Board that approved the project, because I think it was their vision that really brought it to fruition. And I think people are going to be very satisfied with the services down there, since the valley is too small for 2 or 3 hospitals. Thank you. So.
Congratulations, Mr. Valdez.
Yeah, thank you.
Yes. All right, any questions? No? Okay. CEO update?
All right, so I'll get you guys this information, but I thought it would be prudent to give you guys just an overview of the strategic plan that was put in place and some of the changes that happened with Pioneers in that process. So we did adopt a new mission, vision, value at that time. This is all July of last year. Our mission statement is exceptional care always. That was adopted. Vision statement is to be seen and sought after as a leader in healthcare. And then our values are integrity, excellence, compassion, and respect. And one of the things that you'll notice on the new badges, everybody picks one of those, and it's underneath their picture, like the value that they feel most strongly towards. And so it's an opportunity, like where you guys, when you're walking through the hospital and you see some of our folks, as they get their new name badges, you can look at that and see like, oh, why did you choose excellence? Why did you choose respect? But, you know, it would be something you can kind of start a conversation on and learn a little bit about them in the process. So that is in there. So when we do our strategic plan, we base ours off of 5 pillars for the organization, which are people, quality of service, growth, communication, and finance. And so when you do that, you basically you're going to pick something in each of those categories to work on for that entire year, and that's going to be your goal. And so for the people pillar, we wanted to reduce the first year turnover by 30%, which currently right now over half of our folks that come in leave within a year. And so we wanted to make changes in that and reduce that number. Quality of service, we wanted our overall HCAP scores of at least 80%. So kind of what Carol had talked about earlier, that is part of that. That's why we're monitoring that. That's why it's important for you guys to see that as well. The growth pillar, that one is to really work with our workforce and have opportunities for them from a training standpoint to receive training and education. Each one of them has that goal to do at least 2 of those training conferences a year and be able to bring that information back and better the organization through that process and getting that education. So that's on that one. Our communication pillar, obviously this one's also a double-edged sword because you can look at external and internal. We really wanted to focus on our internal communication, and so initially we sent out a communication survey and asked a series of, I think, 10 or 12 questions, 10 questions about our communication, how well it is, how they receive it, how they like to receive communication. And then the idea was to work on those processes and how we can produce more of that communication, because not everybody's going to receive the communication the same way. Some people, email's fine. Some people want it through text. Some people want it through, see it on the bulletin board. So knowing that and kind of making sure that we're communicating that out there so that the staff all feel that they know what's going on, they know why we're moving in the direction that we're moving, was important to us, and that's why we put that in there. And the idea is to subsequently throughout the year, we would take that same survey and do it again and see if we've had any increases in those scores. And at the end, we wanted to make sure that score increased by 20% from the initial one. So then the finance pillar, we wanted to exceed our budgeted profit by 4 times the amount. At that time, that dollar amount was $400,000, so $1.6 million is what we were wanting to make sure that we hit. If we stop today, we're already there, but we've got some fun parts of the year coming up, so that we have to make it through. But those are the strategic plan and the initiatives that the team chose and was voted on by the board to adopt last year. So I want to make you guys aware of that so you can kind of see some of the things that we want to focus on and we'll be focusing on as we move forward, and then that can help you kind of see what that next step might look like as well as for what we want to do the next time. Any questions on any of that? I'll get you copies of this as well, but I just wanted to introduce it to you tonight. Okay, perfect.
Yes,
sir.
So, with the strategic plan, obviously, you have a buy-in from the board and then from the C-suite and, you know, all the medical people, doctors, et cetera. But it's going to be a living document. Right?
Absolutely.
That's going to be changing depending on
Yep.
the needs of.
Yep. And so when we do that, how it was done, once it was finalized, we did a preliminary introduction to the staff on that. And then what we did from there is after the board approved it, then we said, all right, we're good to go. And then each department did the same thing. They had 3 or 4 areas that they were going to focus on, priority areas that they were going to focus on this year. The idea was that on a rotating basis, those department heads would come to this board meeting and report to the board where they were at with their strategic plan, how they're doing, issues that they may be running into, different things like that. Same thing for us. We're to go into each one of the departments on a quarterly basis into their actual meetings, their department meetings, and it gives them the opportunity to report out where they're at with their strategic plan, things that we can do as an executive team to remove any barriers that they're coming across. And then at the same time, it allows us to be able to tell them where we're at with these strategic initiatives, and have that opportunity for that staff to hold us accountable for those results as well, so that they can hear what we're doing and how we're, why, everybody, it all gets tied together, so everybody is kind of working towards that same common goal. And so that's how that was spread out and introduced. And so each one of the department or the executives got with their departments and went through what those 3 to 4 priorities were going to be and established what those underneath one of those pillars. In some cases, some things were very much related to what we did on the overall strategic plan, but there are also instances within each of the departments, in some cases, that it's very different. They have a very unique situation that could be very different than that, and so their plan might be just a little bit different than what would fall under our strategic plan. And so we would allow that to happen because it's something that needed to be adjusted, that needed to be fixed. So they all had the opportunity to do that, and then we bring them all together, and they all had to be approved, and so forth. So that was the idea, the vision of that, because to your point, the worst thing that you can do with a strategic plan is put it together and then put it in a binder, and then it becomes a doorstop, right? It needs to be a living, breathing document. It also needs to be something that we can change on the fly, we can work on, because like if we put something like this together and COVID happens, we gotta change, right? Some of those things will be applicable, but we're gonna make adjustments to them so that they're more applicable to the current situation. Thank you. So a couple other things for the board I want to make you aware of, things that we've been working on. So the Eastern Riverside Imperial County Collaborative is something that Carol and I both went to a couple weeks ago and we participated in. It's an opportunity for all the healthcare in this area, as well as that other East Riverside area, to participate in. Realistically, what they're trying to do is GME programs, which is graduate medical education. It's kind of like residency programs, right? And the idea being, if we can get those programs into our communities, into our hospital, we're most likely going to be able to keep those folks as well, because they'll come in kind of to the same point that Carol alluded to, as we do those programs with the nurses. And so we have those shortages in our area of providers, and we want to be able to fill that. And this is an opportunity for us to do that and get people engaged from the beginning, because it is very difficult to recruit. And so this is a grant that is being put together that we're participating in that will allow monies to pay for some of those type of things. We are looking at other GME opportunities as well that we can do within our organization. So those will be things that you guys will see forthcoming as they start to mature a little bit and we start to get a little bit more into that. You guys will be able to see that as well. So that's something you just want to put on your radar. We've already kind of done some of the CHOW updates, and so I'm not going to belabor that much longer than need to, but it is something that is flowing. It's moving pretty quickly. Obviously, we have dates associated with that we have to make sure we hit all of our targets by. And so the team's done a good job with that. And we should have that all finalized by next week. And so I also want to thank you guys for finishing that paperwork that we needed from you guys, because that helped us out quite a bit. That's going to be a big piece. One other thing to make the board aware of is the changeover to our call center. This might be something that you guys will hear about. Our call center is now with Ring Central. This allows us to do a lot of things that we weren't able to do before. There's a lot of things that we're able to track. Previously, we didn't have the ability like we do now to record those calls for quality assurance. And in this case, there's an AI printout of it as well, so you can actually get it in writing. So you can skim through it instead of having to listen through the whole thing to be able to find that kind of stuff. It gives us very good data as far as the number of calls that are coming through. The first day alone, we had over 1,000 calls that came through our call center. And now we'll be able to better track that data. When people are saying they're having a hard time getting through to our system, we're going to be able to track that better. We're going to be able to see, where that could potentially, where some of those issues are. If it's software related, if it's something else, we're going to be able to track that and be able to have better data on that to be able to serve our customers better. So it's something I'm pretty excited about. Obviously, with it, like any other change, there's some hiccups along the way that we're working through. Some of that being where some of the calls are getting routed, because some people are used to calling us already, and they already know, like, okay, I'm going to hit 3 and I'm going to get Carol, for example. Now they hit 3 and they get Carly, and they're like, whoa, what's going on? So there's some stuff like that people have to get used to. But so far, it's actually gone really well. I've had conversations with some of the staff in the call center about it. They like it. It is something that is different, but they do like how it is set up and what that can mean for them going forward. So just want to make you aware of that. We are also, Carol and I had an opportunity to meet with another group to look at neuro programs and being able to bring neuro services into our community, into our ER in particular, to be able to provide that service. There is opportunity there for outpatient services as well. Currently, it's all via tele. One of the things that is kind of exciting about it is this first group that we've talked to, and we have a couple other that we're going to be talking to as well. But this first group that we had that conversation with will work with us to become stroke certified, which I think will be huge for our organization and for our community, right? So those are things that we're looking at to be able to provide some of those services that are currently not being provided in the area. So there'll be more to come on that as we hear from some of the other folks that we have some meetings set up for in the future. The couple of things from the email standpoint. We're very close to getting everything switched over to the IVHD emails for our staff. You guys will probably get switched over this weekend, just so that you're aware of the new server, the email server. Some of it's already there right now, but we have some of the spam stuff that is programs that we have on ours to make sure that it filters everything appropriately. We don't get stuff you're not supposed to, in particular malware and antivirus kind of stuff. That will be the piece that should happen over this weekend, and will go out to you guys. So currently we have a number of emails that go out to all the staff. It's like IVHD, everybody is what it would be. So when that happens, you guys will also receive those emails as well. Every day we do a safety meeting, and in that safety huddle, there's notes that come out, and we send it out to everybody at the facility and all of our staff, and so you guys will have access to those as well. And Ola already sees them now because she still has the other email and is currently getting those. But those will be type of things that you'll get. You'll also see other things that we send out, just like things that are coming up to make everybody aware of events or whatever. You guys will get to see that as well and have opportunity to come in and participate if you wanted to, which I know the staff would enjoy having you guys do that when you're able to. So that is something that we're hoping next week we'll be able to potentially do that. If not, it'll be within the next 2 weeks that it'll all be done for everybody. I know it was brought to the board's attention before about H-1B visas and that being an issue, so I just wanted to give you guys an update on that. We have 6 members of our team that are here on H-1B visas, and we've actually engaged another part of the group that is part of Adriana's law firm to help us with that process, and they've been absolutely amazing. We've had sit-down conversations with all of the staff initially, just to kind of go over all the things that needed to happen. This week, we actually sat down with the staff and had the lawyers on as well to be able to make sure that they had any questions, we could figure out what needs to happen. For the most part, everybody's in a pretty good spot. There are some people, of course, that are a little higher priority than others, just depending on when things are coming around. And we did have one issue that it's not our issue, but we're going to help them work through that process as we go. So that is coming along really well. They've really helped us out quite a bit. Also given us some things that we weren't aware of before that we're doing now, so that we can make sure that those folks that come and become part of our team are going to be taken care of. So it was nice to be able to have that part of it as well. There are a couple of things that we're working on. There's a grant that we're working on to put some EV chargers out here. We have some EV chargers now. They're pretty old, and some of them don't work. And one of the issues that we have now is we have a number of providers that come from around that provide services here, and some of them have EVs, and so they like to be able to charge while they're here waiting, and some people will sit on them too long and so forth. So we found a grant to be able to upgrade them and add some more, but they're also going to be paid. So that way, when they can use that and they can go ahead and pay for it and pay for the electricity, because like I told one of the providers, I'm like, we don't pay gas for anybody else. Why should we pay for the electricity for that? And then they said they would be fine paying for it, so we'll set it up to do that. And then, of course, if they sit there too long, then it'll charge them even more. So that'll be an incentive for them to go and move their cars so somebody else can use it. But that's something that we're working on. There's a grant for, and so we want to be able to put that service here, or upgrade the service that we currently have on campus now for that. There also the HASDAC meeting, which is the Hospital Association of San Diego and Imperial County, which both Pablo and I sit on the board for. We met and had a meeting a couple weeks ago. One of the things that was brought up, and I just want to put this out there for the board's information, has to do with the Office of Healthcare Accountability, which is a fairly new group that has been put together by the state. They're limiting expenses and growth, and if you go over those, then there are penalties associated with that. It's a very interesting program that they're trying to do. Obviously, one of the things that they're trying to do with that program, I don't necessarily agree with it, but it was basically put together to try to bring the cost of healthcare down. So, for example, there's a growth cap target for this year, which is only 3.5%. Next year, it's also 3.5%, and then it goes to 3.2, 3.2, and 3%. Telling us we can't grow any faster than that, and our expenses can't go up any more than that. Oddly enough, the state has also said, hey, we put this minimum wage mandate in place as well, and every year you have to increase that 3.5%. So our expenses can't go up more than 3% in a couple of years, but we have to increase our payroll by 3.5%. So it makes it like the right hand doesn't know what that left hand is doing, which I'm sure we all know that that's kind of how it works here. But that is something to kind of put on your radar, because as we go through this process, they will be watching and looking at it. They will actually have to sign off, most likely, on the merger with ECRMC, and I'm sure we'll be watched. Right now, neither ourselves here or ECRMC are on the watch list. But this merger could put us on that. So just something to be aware of as we kind of navigate what that's going to look like. As we go through 2025, there's nothing that's going to happen from here that's enforceable. They're just going to kind of like, hey, here's what's going on. 2026, there'll be an enforceable spending, but it's kind of like the government does everything else. It's all from stuff that happened technically 2 years ago, that they're saying, hey, you need to fix this now. But it would have been nice if we know that a year ago, so we could fix it because we may be in the same boat next year. So again, I'm just putting it on your radar because those are things that we have to worry about on this end that we're really paying attention to. And so it's going to be something that you guys as a board need to be familiar with and be aware of as we move forward. And then finally, I also want to make sure that we're aware that on that report, you would have seen that we had some towers that we purchased on that with the loan that we received, right? Those towers, they're about 1.5 years old now, and we've had some terrible luck with them as far as them breaking down. Again, it kind of goes to, like we talked about before, there's different models, and we bought the lowest one we could at that point in time. I don't know if that has anything to do with it, but we had 4 of them essentially come out on us. Radio towers? They're towers that we use for surgery. Yeah, sorry. Yep. So those are things that have been concerning for us. We've been working with the vendor, and we have a loaner as they're looking at our other machine right now to see what potentially could be the cause of that. Obviously, our providers that use that are very apprehensive to do so because of the experience that they've had with them going down, and have asked for us to look at other options to potentially purchase a different brand and different towers. So those will be things that we're going to be looking at, but I wanted you guys as a board to be aware of that, that those things have, that we have had that, and that's something that we're looking at and working with right now. So in case you do have somebody that talks to you or comes to you, you would know that we are aware of it. It is something that we're working on. So you have a question?
Yeah.
See it?
El Centro Regional, do they use the same type of towers?
I don't know if they have Olympus. I know they were moving away from Olympus, but I don't know if that the towers that they have right now. Yeah.
They use.
Yeah,
If
absolutely.
theirs don't go down, then that might be an option.
Yep. So wanted to make you aware of that. And then the one thing I want to bring to the board's attention that we're going to need to make sure that we look at as we move forward has to do with the urgent care. As we look at how we want to manage the CT side, the pharmacy side, those are all things that are going to become questions for us that we need to answer here soon. And then also, just as that reminder, the way that lease is set up, it's currently for both sides, so if we need to change that, the way that looks, that needs to happen here pretty soon, because we've got until essentially April-ish before the 4 months is up. And so we'll have to take some action on that here soon, so I just want to make sure that the board's aware of that. And then the last thing I have for you guys on my report is last Friday, they did do a hot wings contest here, which I got nominated for. It was supposed to be volunteer, but I was voluntold. And I just want to say I was robbed. I finished all mine and I still didn't win. And the guy who did win, he didn't finish, but his bones were cleaner. So just I just wanted you guys to be aware of that because I think that's important.
Don't be a loser, Chris.
I'm trying not to, but I ate them all. So.
I'll be your wingman, no pun intended.
But there are, to that point, like I said, there are things like that we do from time to time that, if you guys want to participate in, we appreciate that. As we, some things to be aware of in the near future, in May in particular, is National Hospital and Nursing Home Week. We have a hospital, we have a nursing home. They coincide. at the same time, and we usually put together a pretty good week for our staff. Different things where they can kind of dress up differently that week, and we provide, like last year we did a breakfast for them. One time we grilled for them. We did pizza, we did shaved ice, and, different things like that we. Yeah. Oh yeah, we did a dunk booth and stuff like that. And, so when those events happen, you guys are more than welcome to come and participate. Like that's what we do is we serve and do that kind of stuff and take care of the staff as they come through. And we'd love to have you guys participate in that with us as well as you're able to. So you'll see that stuff coming up. I just want to put it on your radar. That's all for my report. Thank you.
General Counsel update.
Quick update with respect to Pioneers Memorial Healthcare District versus IVHD litigation. A notice of abandonment was filed of the appeal, and that was received and filed by the court today. So the case is complete with respect to the Court of Appeal, and that's public information, so I just wanted to fill the board and let you know where we're at with that.
Do you have any items for future agenda?
Changing it up to try to go down
If you want to talk about it right now, so time to do.
And something we can, something we can do also is bring back the calendar of regular meeting dates, and then just assign locations to the dates so that you're rotating through if you'd like. So we can, I'll circle back with Chris, and then we can bring that. It could be like a consent item on the next agenda. Okay.
I think also with that, if we're going to do that, one of the other things that we'll want to do is just with the timing of everything, in particular for our med staff, and when the information comes to you guys to approve the credentialing, it is fairly time sensitive, and so normally because we were doing that with Pioneers towards the end of the month, it worked out and correlated with their MEC meeting, and then they were able to get the information to us and we were able to get it in. So having that second meeting in the month, if we want to continue to hold these on that on second Thursday, having a meeting like that we do the finances and do the MEC, it will be advantageous, particularly for the med staff, for us to be able to do that, so they're not waiting until that time in the middle of the next month. And then the other side of that too is I think it will be advantageous for you guys, because when we present finances 3 weeks or 3.5 weeks into it, it's going to be for that prior month. If you waited, we're always going to be a month and a half behind, which makes it harder to pivot if we need to on some of those. So that would be something I would take into consideration for a future agenda item as well, that we would need to put that in correlation with the locations.
Perfect. If not, the board's going to break into closed session at 7 p.m.
Thank you.
So now we're going to go back into open session, out of closed at 9:46. Do we have a report out of closed session?
Yes, Madam Chair. The report on the last closed session item, which was public employee discipline dismissal release. A vote was made by Director Goodsell, seconded by Director Proctor, to thank Ms. Carly Loper for her service as acting CEO of Pioneers before IVHD's takeover. The board voted to remove her from that acting CEO role and place her back into her role as Chief Financial Officer under the supervision of the CEO, effective February 3rd, 2025. The vote was unanimous. That's my only report out of closed session. There was no other reportable action taken.
Awesome. And with that, I will adjourn this meeting at 9:47 p.m. until the next regularly scheduled meeting, March 13th.